Assalamu alaikum, doctors. Today we'll start the first chapter talking about diagnosis. What is diagnosis? Diagnosis is the art of detecting deviation from health. So the purpose of it is to determine what problem the patient is having and why the problem has happened. We start off by taking the chief complaint, which is to know the reason of the patient visit. We have already printed forms that can be used to write down the patient information and can be used as a future record. Then we ask for the medical history, which is the medical conditions of the patient with all the possible disease that he may have, like the cardiovascular diseases, infarctions, hypertension, asthma, hepatitis, bleeding disorders, rheumatoid arthritis, and many others. These must be known from the doctor and be taken in perspective. As for the dental history is asking the patient 5 questions to give us a perspective of what we are dealing with. The first question is, can you point to the offending teeth? The patient's ability to point to the source of pain makes the diagnostic procedure more obvious and certain. Second question, when did the symptoms first occur? Was it associated with biting a hard object? Did the condition happen concurrently with other symptoms like sinusitis or headache? Third question, how intense is the pain? Scale it from 1 to 10, please. Can you tell me how painful do you feel? The intensity level gives the dentist a clue about what he is dealing with. Fourth question, what produces or reduces the symptoms? Is mastication? Is it cold or hot drinks? And what resolves the pain? These questions help us to know to which extent the infection has reached in the tooth. The fifth question is, do the symptoms subside shortly, or do they linger after they are provoked? Then we go to the extraoral examination. We must take notice to any possible swelling on the patient face, because it is usually an odontogenic origin, which means that the pus is extruding into the facial spaces. Let's talk about the facial spaces, which are the spaces between the fascia that is covering the underlying structures like the muscles, the glands, the veins, and the arteries. These spaces are usually not present in the normal condition, but they are filled with pus when there is an infection. So let's take an example here. Here we can notice that the nasolabial fold has gone and the infection has reached to the eye and made it close. When we see this, our examination goes to the canine space that it is filled with the infection. So our diagnosis is directed to the canine area. In this situation, we can see a swell on the upper lip and the area under the nose. So we suspect that the source of infection are the central maxillary incisors. As for the buccal space, it is usually connected to the maxillary tooth, whether they are the premolars or the molars. Upper or lower does not matter, and it is associated with the mandibular first molar in particular. As for the second and third molar, usually their extrusion are in the lingual space. Here we can see the patient with a buccal infection on the buccal space. When we examined intraorally, we saw that the first molar was the source of infection. After radiograph examination, we can see that the first molar was involved and a lesion is present. When the swelling is in the submental area, usually the mandibular incisors are the cause of the disease. Here we can see that there is an extraoral drainage associated with the periapical disease of the mandibular right canine. When we did the incision and treating the canine, after 3 months we saw that the healing has occurred of the incision, but a scar remained. And this is usually a thing with an extraoral drainage, that the tissue do not go to its original shape. Like this lady that had an extraoral drainage from her chin. The source of infection were the mandibular incisors. We can see that the skin had a concavity in the area after the healing. Let's start with the intraoral examination. What can we see? We can see an intraoral swelling that is associated with the apical part of the tooth that indicates a periradicular disease. The location of the apex determines where the swelling happens and its location and spread. For example, if the root apex of a mandibular teeth is under the attachment of the muscle, usually the extrusion of the pus appears extraorally. On the other hand, and if the attachment of the apex of maxillary tooth is superior to the muscle attachment, the swelling will be extraorally to the spaces above. When the opposite happens, the swelling becomes intraorally. So the muscle attachment in relation to the apex position is important in determining the location of the swelling. Sometimes this swell opens in the sinus tract. What is a sinus tract? It is actually a connection between the apex of the root with the gingival surface. It is usually lined with the granulation tissue, which indicates inflammation. Usually it is not painful, and the history of the pain is varying magnitude of discomfort before the opening of it. So actually the sinus tract decreases the pressure around the periradicular space, and relieves the symptoms of the patient. We can use a 25 or 30 𝐏𝐚𝐭𝐡𝒊𝒂𝒈𝒏 cone to detect the source of infection. We can insert it into the sinus tract and feel the resistance. Then a radiograph is taken and the source is detected. What is the differential diagnosis between periodontal lesion pocket and a root fracture pocket? A root fracture pocket is usually a narrow, isolated, deep pocket around the tooth with a J-shaped radiolocity. As for the primary periodontal lesion, it is usually a pocket is large coronally, and the alveolar bone loss around the root is huge. One of the diagnostic procedures that can be done is the percussion. Percussion indicates the inflammation of the periodontal ligament, which can be secondary to physical trauma or occlusal prematurities, periodontal disease, or the extension of pulpal disease into the periodontal ligament. So it is only gives us the clue that there is a periodontitis, but it does not gives us what is actually the source of this inflammation that happened. So further examination is recommended. The pocket of an endodontic origin will resolve after the endodontic procedure is performed. As for a primary periodontal pocket that has no connection with the tooth, will not resolve after any endodontic treatment is performed. What about the pulp tests, which are the thermal, the cold, and the electrical? If the tooth gave us one of these three responses, then we are dealing with abnormal response. The first one is lack of response to the stimulus. The second one is lingering of a painful sensation after the stimulus is removed. The third one is an immediate sensation of pain and when the stimulus is placed on the tooth. If mature non-traumatized tooth did not respond to any of the cold, electric, or thermal examinations, then the pulp can be considered necrotic. However, a multi-rooted tooth with at least one root containing vital pulp tissue may respond to a cold test and electric pulp test even if one or more of the roots contain necrotic pulp tissue. Bite test is another indication of the apical periodontitis. It can be also a differential diagnostic indication between a cracked tooth or an apical periodontitis. If the periradicular periodontitis is present, the tooth will respond with a pain to percussion and biting test regardless of where the pressure is applied to the coronal part of the tooth. However, a cracked tooth or a fractured cusp will typically give pain when the pressure is applied in a certain direction to one cusp or section of the tooth. So it is recommended that the bite test is performed on each cusp by its own. Staining and transillumination are ways to detect any fracture that is happening. By using methylene blue dye and applying it with a cotton tip on the surface and remove any excess with a 70% of alcohol, we can see that the residual dye gives us where is the crack is present. For the transillumination, also when the light is passed through the crack, it tells us where it is present. As for radiography, it cannot be considered it cannot be considered as a solely source of diagnosis. Here we have a central lower incisor that has a radiolosity in the apex area. However, the tooth was vital, no caries was present, so the tooth was suspicious that this lesion is not an odontogenic origin, and after the extraction of this lesion, we saw that it was a cementoma. These lines are merely cracks in the enamel. They do not extend into the dentine or the dentin, and they can be naturally found or develop after a trauma. No treatment is necessary unless they create a cosmetic issue for the patient. For fractures, they extend deeper into the dentin, and the dye or transillumination that we talked about previously can help to visualize the potential root fracture. A fractured tooth may be treated by a simple restoration or an endodontic procedure or even extraction. When the dentist suspicious a fracture, the patient must be informed because the prognosis of the tooth decreases significantly. The vertical root fracture is one of the most common reasons for the failure of an endodontic procedure. After the dentist recognized that the presence of the vertical root fracture, he or she can go to a conclusion of the need of doing a retreatment of the tooth, or go for or say that the tooth is hopeless and extraction must be performed. Let's see this case. We have a second mandibular premolar with a gold onlay and a deep pocket that with the tooth was non-vital. After extraction, we can see that the vertical root fracture was on the distal side of the root. For the second case, we can see the deep pocket that is associated, the J-shaped radiolucency, and the long fit of a post. After extraction, the vertical root fracture was so obvious. Let's talk about what is the differential diagnosis between the reversible pulpitis and the hypersensitivity, because they are clinically have a similar symptoms of sharp, quickly reversible pain. For the hypersensitivity, it is associated with the cervical part of the tooth. It is caused by the exposure of the odontoblastic fibers. So the fluid inside, the movement of the fluid inside by the stimulus causes the pain. Usually, the hypersensitivity is associated with the sound tooth that has no caries or any restoration, and it can be caused by scaling the tooth or by doing the bleaching procedures. As for the reversible pulpitis, it is associated with the caries or a recent dental treatment or defective restorations. Conservative removal of the irritant will resolve the symptoms. When the pulp loses its ability to heal, an irreversible pulpitis happens. To finish things up, we will talk about the referred pain. Referred pain is defined as pain in one part of the body that is distant from the actual source of the pain. So, it is for the tooth, it is usually associated with the mandibular or the maxillary posterior tooth, and the pain is referred to the periauricular area or to the opposite arch. Anterior teeth seldom to refer pain to other tooth. After all the testing procedures are complete, the dentist can determine that the pain is not an odontogenic origin. Further examinations must be performed. We will talk about the non-odontogenic origin pain sources in the preceding sections. See you. Salam. Assalamu alaikum. Welcome to the summary of the episode 1. We talked about diagnosis. What is diagnosis? It is the detecting and distinguishing deviation from health. So, we must know what is the problem that the patient is having and why did it happen. We first know the chief complaint that brought the patient to our office. Then we must take the medical history, knowing all the medical conditions that the patient is having. After that, we ask 5 questions under the title of dental history. Can you point to the offending tooth? When did the symptoms first occur? How intense is the pain? What produces or reduces the symptoms? Finally, do the symptoms subside shortly or do they linger? After that, we must do the extraoral examination by examining the patient's face before he or she opens their mouth and notice any swelling happened. That gives us a clue where is the source of infection is located. What determines the location of the swell, whether it is external or internal, is the location of the apex with reference to the muscle attachment. If maxillary root apices are superior to muscle attachment and mandibular root apices is inferior to muscle attachment, the pus will drain extraorally, and the opposite is true for intraoral drainage. Then we go with our intraoral examination. We examine the soft tissues and we examine the hard tissues, which are the bone, which are the tooth. Then we do the pulp vitality test. For our soft tissue examination, if we detect any sinus tract, a 𝐏𝐚𝐭𝐡𝐰𝐴 file is inserted inside the sinus tract and a radiographic picture is taken. Then, if we examine the periodontal pocket, if it is wide and the boneless is widespread around the tooth, it is associated usually with an infected tooth with an odontogenic origin. The gingival swelling is associated with periradicular infection and it is usually located in the apical part of the gingiva. The hard tissue examination, which is the grazed lines, the cracks or the fractures, we talked how to distinguish between the 3 of them. For the grazed lines, they are merely cracks in the enamel that do not extend into the dentin and either occur naturally or develop after trauma. No treatment is necessary unless they create a cosmetic issue. For cracks, it extends deeper into the dentin. A fractured tooth may be treated by a simple restoration or an endodontic procedure or even extraction. Dyes and transillumination are helpful for visualizing, for knowing the potential root fracture. As for vertical root fracture, it is associated with an isolated deep pocket with J-shaped radiolucency around the root. The pulp vitality test, thermal, cold, or electric. If the tooth gave us one of these 3 responses, then a problem is happening to the tooth. First, lack of response to the stimulus. Second, lingering or intensification of a pain sensation after the stimulus is removed. 3. Immediate painful sensation as soon as the stimulus is placed on the tooth. If the tooth did not respond to any of the pulpal vitality tests like heat, cold, or electric, then it may be a necrotic pulp. What is the differential diagnosis between the reversible pulpitis and the hypersensitivity? Reversible pulpitis is a causative factor its causative factors include caries, exposed dentin, recent dental treatment, and effective restorations. Conservative removal of the irritant will resolve the symptoms. Exposed dentin in the cervical area of the tooth accounts for most of the cases diagnosed as dentin sensitivity. Periodontal scaling tooth bleaching material can cause this sensitivity. For the referred pain, it is the pain that is happening in one place and felt in a distant place from the original pain or from the origin of the pain. For the mandibular posterior teeth tend to transmit referred pain to the periauricular area more often than maxillary posterior tooth. Anterior teeth seldom refer pain to other teeth or to the opposite arches, whereas posterior teeth may refer pain to the opposite arch. After all testing procedures are complete, the dentist can determine that the pain is not an odontogenic origin. So, the origin of the non-odontogenic origin pain will be discussed in further sections, in further episodes. So, non-odontogenic origin pain sources will be discussed in further episodes. To be continued. See you soon.